dictum is any patient of renal problem, renal failure, should be treated as acute until unless proved otherwise. This is basic dictum. Reason being, suppose about the second case, she was a lady who was having diabetes for last 20 years. Till 10 days back, she was doing absolutely fine. She has no problem except frothing in the urine. She was doing very well. Suddenly, she had developed a carbuncle, and after this carbuncle, she had rapid rise of creatinine and urea, landed with dialysis dependent condition. So, if you treat this patient as chronic, if you think this is chronic, so for her, life is gone. She is dialysis dependent, she has to think about family, she has to think about the finances. But think about इस पेशेंट में एक हफ्ते पहले तक she was doing everything perfectly all right. तो एक हफ्ते के अंदर बेसिकली कार्बंकल हुआ, उसके बाद से एकदम she has become dialysis dependent. So obviously this is acute or acute number. Number two, regarding your second question, what is the earliest parameter how to say whether it's a renal problem is there or not? Creatinine will rise if there is loss of GFR of around 50%. तो earliest parameter is हम clinical level पे भी we should ask our laboratories to do GFR in each and every patient. अगर वो GFR करके हमें दे रहे हैं तो अगर 60 से कम GFR है, persistently 60 से कम आ रहा है, जी सर, they do estimated GFR. सर हाँ नहीं ठीक है, अब सर GFR estimation के लिए बहुत सारे ऐसे वो आ गए हैं, इवन जो हम सॉफ्टवेयर्स आ गए हैं तो फटाफट आप कैलकुलेट करके that is also reasonably good. तो हम क्रिएटिव पे डिपेंड ना करें. एक कोई व्यक्ति जो 30-40 किलो का आदमी है, जो मसल मास बिल्कुल नहीं है, उसके लिए 1.2 क्रिएटिन 1.4 क्रिएटिन में भी GFR of 40, और मस्कुलर आदमी बहुत ज्यादा है, उसके लिए हो सकता है क्रिएटिन of 1.5 with GFR will be of 70 or 80. So what is more important is GFR estimation. तो हम कैलकुलेट कर लें या एस्टिमेट कर लें, जैसे भी करें, पर we should ask our laboratories to give us GFR in each and every patient. अब ज़्यादातर लैब जैसे हम BR इंस्टीट्यूट इन बरेली, अब नेशनल लेवल पे सब ये हो गया है, जितनी नेशनल लेबोरेटरीज हैं जिनका पैन इंडिया नेटवर्क है, they always give creatinine जहाँ देंगे साथ में GFR जरूर देंगे. इसी वजह से because this is going to be regulatory compulsion in short while.
What is invasive GFR?
सर वो उसमें यह है कि आप कंपाउंड भले DT पे कर लें, DT पे डाल के उसके अंदर उसका देख लें कि कितने टाइम में कितना एक्रीट हुआ, या हेलमेट, but they are all costly and not available.
Not required for all practical purposes.
नहीं सर,
invasive is not.
For all practical purposes we should ask for GFR, not creatinine जहाँ भी दें, GFR जरूर लेबोरेटरी से कहते हैं, they will do it.
But I would like to say, sir, that we should not ask laboratories to do GFR, because they also estimate GFR. We should ourselves calculate GFR. Because important that I would like to say that in acute cases they will give you GFR in every report, and then you will it will mislead you. But the problem with acute patients is that even creatinine changes, after some time. It takes time for creatinine to increase in patient with AKI also, sir. So that's all I think.
In a young patient of 35 years,
Yes,
diabetes of 10 years duration with hypertension and CKD creatinine up to 4,
yes, sir.
having passing a lot of protein in urine with +4,
Yes, sir.
shouldn't we think of nephrotic syndrome
So
associated with diabetes? Because the treatment will change.
okay,
when
sir.
it is
But if patient is having long-term diabetes, and having heavy proteinuria, because also diabetic nephropathy is also a cause of heavy proteinuria. So simply heavy proteinuria is not, fitting in the diagnosis that patient is having non-diabetic kidney disease. Patient can have non-diabetic kidney disease. Then we have to think other factors also. That is patient having long-term diabetes? It was uncontrolled? Then patient having diabetic retinopathy or macrovascular complication as well, neuropathy also or not? Then we should think that okay, patient is having only proteinuria, no RBCs are there. Because every glomerulonephropathy can also present in diabetic patient also. But at least we should have something to say that patient is having not non-diabetic kidney disease. Then is there indication that okay, you can go for biopsy, but otherwise it has to it will turn out to be diabetic nephropathy, and then you first hand know that okay, patient is diabetic nephropathy. So why should we go for that invasive testing of renal biopsy or something like that? So that is my point.